services include pre-recorded classes, live doubt clarification, and more personalized one-to-one guidance, as well as notes are the special features of this subscription. And we also offer you quick revision examination module. You can use the below mentioned code for discount on the subscription. So why wait? Book a slot for personalized counseling session using the code. So about this internal exam marathon classes, which we have started from last month, it's a duration of about 45 days. So here we offer you rapid revision of all important questions, as well as quick revision of volatile facts. Multiple choice questions will be covered, and also we assure you with all this top grades in the exam. So this is beneficial for everyone, for all the university exams. You can use the code Dr. Divya 20 for the first free live class. So we'll begin today's series. So here we have these topics today will be covered, like mediastinum, thoracic diaphragm, thoracic duct, azygous system of veins, internal thoracic artery, typical intercostal nerve, trachea, sternal angle, and transverse thoracic muscle. So all these are very important topics. So most of the MCQs are asked from here, and 3 marks and 5 marks questions are asked from this. So first we'll go to the essay topics, that is essay topics. So we have first question, that is the mediastinum. So when mediastinum is asked, you need to answer the question on the following headings, that is definition, subdivisions, content, the boundaries and the contents of each of the subdivisions, and the applied aspects. So when we say mediastinum, the thoracic mediastinum is the space. So it is the space between the right and left pleural sacs, and it is limited on each side by the mediastinal pleura. Okay, so that is the space. So it will extend above from the thoracic inlet and below up to the diaphragm. And sternum in the front, so behind from the first to 12th thoracic vertebrae. So there it will be. So this is the boundaries and the extent of the mediastinum. So why this mediastinum is important? So mediastinum is very important because it houses many important structures there, mainly the heart, all the tubes, that is the esophagus, then the trachea is there. Then also we have the great vessels in that region. So that is why the mediastinum plays a very important role. So this is the boundaries which I said. So anteriorly it is the sternum, posteriorly it is the 12th thoracic vertebrae, superiorly it is the thoracic inlet here, and inferiorly is the diaphragm. So these are all the important structures. So on the right side, we see the zygous vein, the 3 neural structures, that is the sympathetic chain, right vagus, right phrenic nerve, as well as the esophagus, trachea, right brachiocephalic vein, superior vena cava, root of the right lung, right atrium, which is covered with the pericardium. So from the left side, we are able to see the trachea, esophagus also we can see here. Along with that, the left subclavian, the left common carotid, the arch of aorta, left recurrent laryngeal nerve, the left ventricle, the root of the left lung, okay, the 3 neural structures, that is sympathetic chain, left vagus, and left phrenic nerve. We can see here, as well as the thoracic duct. So in this way, all the most important structures are located in the mediastinum. So this mediastinum, next the subdivisions. Okay, so first you will say what is mediastinum, and you will generalize the boundaries of it and why it is important because of all the important structures there. So subdivisions, when we come to, so we draw a line, imaginary line, that is from the sternal angle up to the lower border of T4. Okay, so above that will be the superior mediastinum. Below will be the inferior mediastinum. So inferior mediastinum is further divided into anterior, middle, and posterior mediastinum. So these are the main subdivisions. So superior mediastinum is very important and posterior mediastinum is important. Middle mediastinum, mainly the heart will be the main content there. So superior mediastinum, when we see the boundaries, superiorly it will be the plane of thoracic inlet. Below will be the imaginary line drawn from the sternal angle to the lower border of T4. Anteriorly, it will be the manubrium sterni, and posteriorly it will be the fourth thoracic vertebrae. And the contents here. So contents, what do we see in this? So here, this is a transverse section. This is like from the anterior view, what we see. Okay. So at this level, so what we are seeing here, we are seeing the arch of aorta with these three branches. The trachea, esophagus is seen. The left vagus as well as the left recurrent laryngeal nerve is seen. The right vagus here. Then these are right and left brachiocephalic veins. And this is the superior vena cava. So these structures mainly form the contents of the superior mediastinum. So in a cross section, we can see the same thing. So this is the sternum, that is the manubrium sterni. So here we see two muscles, sternohyoid and sternothyroid. This is the thymus gland. Here we see the brachiocephalic, right brachiocephalic and left brachiocephalic vein. These are the three branches of the arch of aorta, that is the brachiocephalic artery, the left common carotid and left subclavian. This is trachea, this is esophagus behind. This is the vertebrae, thoracic vertebrae, and here we have the longus coeli muscle. This is the sympathetic chain. Here we see the nerves, that is, this is the right vagus, this is the left vagus, recurrent laryngeal and left phrenic. Okay, left and right phrenic. So these are the contents. You can either draw this diagram or this diagram and show the contents along with this diagram. The anterior mediastinum, when we see here, we just see pericardiophrenik ligaments here, and sternopericardial ligaments are seen here with little bit of connective tissue. Not major structures are located here. It's a small space. In the middle mediastinum here, we see mainly the heart and the pericardium covering it with the root of the great vessels, that is the pulmonary trunk, descending aorta, and the superior vena cava is seen. Then the posterior mediastinum. So posterior mediastinum, when we say here, this is the boundaries. Boundaries of the posterior mediastinum is superiorly will be the imaginary line, and inferiorly will be the diaphragm. Anteriorly will be the pericardium and the heart, and posteriorly it will be the T5 to T12 vertebrae. So what are the contents here? We will see the bifurcation of the trachea. The esophagus is seen, the thoracic duct is seen, the azygous vein. This is the descending aorta. Okay, and tracheobronchial lymph nodes. So they form the contents there. So when we write mediastinum, so first what are we going to write? So first thing you need to write about the definition. Okay, so mediastinum. So we mentioned about the definition, so that it is a space between the two pleura, and then you write the subdivisions. Then you write about the boundaries of each of the subdivisions and the contents of it. So among this, you need to remember very well the superior mediastinum and the posterior mediastinum. Then you talk about the applied aspects. Applied aspects here, it is to concern. So we will see pericardial effusion is common, or injury to those structures which are present there in the superior or posterior mediastinum can occur. So these are the things which you need to write for the mediastinum. Okay. So on these headings, you need to write the answer. So the next question is thoracic diaphragm. So when we talk about thoracic diaphragm, so diaphragm, there are many in the body. Okay, so that is why it's specified as thoracic diaphragm. So what do we mean by that? So here also you need to write the definition, the location of it, then the origin insertion, the openings and structures passing through the openings, and the applied aspects. So what is diaphragm? So it is a dome shaped. So if you see, it is a dome shaped musculoaponeurotic partition which intervenes between the thorax and the abdomen. Okay, so it forms the roof of the abdomen. So Here, the thoracic surface. So if you see this thoracic surface of the diaphragm, it is convex on the right and left side. And in the center, it is depressed in the middle. Okay. So summit of this convexity, it is called as the cupola. And the right cupola is slightly higher compared to the left dome. Okay. So this dome or the cupola, right, is higher compared to the left. And this is mainly because of the presence of the liver here. So here, if you see the peripheral part of it, okay, so the peripheral part of it, it is muscular, okay, and the central part is tendinous, okay, so which is occupied by the central tendon. So coming to the origin and insertion when we talk about it. So origin, it arises from the inner surface of the thoracic outlet. Now, this is the thoracic outlet, right? So it originates from the inner surface of the thoracic outlet, and the origin is arranged in three groups. That is, we have the sternal origin, we have the costal origin, and we have the vertebral origin. Okay. So what is the sternal origin? Sternal origin is by two slips. Okay, from the back of the xiphoid process. Okay, so from the back of the xiphoid process, by two slips of muscles, it originates. Then the costal origin. Costal origin is from the inner surface of the lower 6 ribs as well as the costal cartilages. Okay, so lower 6 costal ribs and cartilages, it has the origin. And we have one more, that is the vertebral origin. Okay, vertebral origin, here in the vertebrae, it arises from three sources. So first is, it comes as a pair of crura. Okay, so this is known as crura. So for the right and left crura. So the right crura or the crus, okay, is longer and more muscular compared to the left side. And it arises from the front of the bodies. Okay, so from the bodies as well as from the intervertebral disc here, okay, of the upper 3 lumbar vertebrae. Okay. So the left, okay, so the left crus here, the left crus, it arises from the bodies and the disc of the upper 2 lumbar vertebrae. Okay, it comes only from the upper 2, whereas this comes from the upper 3 lumbar vertebrae. So both crura, they are connected across the midline, okay, across the midline by a median arcuate ligament. So if you see here, you can see this is the right crura and this is the left crura. So here will be the median arcuate ligament, okay, connected. So the left crus is connected to the bare area on the posterior surface of the cardiac end of the stomach by the gastrophrenic ligament. So this will be the cardiac end of the stomach here. So here it will be connected. This is one, okay, that is from the vertebrae. The second is, it arises as a pair of median arcuate ligaments, okay, median arcuate ligament, that is in the center here. So each ligament bridges across the, here you can see, okay, this is the part. So from a pair of median arcuate ligaments, or it is also called as medial lumbosacral arch. So each ligament, it bridges across the front of the psoas major and is formed by the thickening of the psoas fascia. Okay, so it is attached medially to the body of the first or second lumbar vertebrae, and it laterally it is attached to the tip of the transverse flow process of the first lumbar vertebrae. Okay, so it is across this. And then there is the lateral arcuate ligament, okay, here, this side, lateral arcuate ligament. So this lateral arcuate ligament arches in front of the quadratus lumborum muscle. So here is the, so here you can see this is the median and this is the lateral. So median arcuate ligament across the psoas major muscle, whereas this muscle, this one is across the quadratus lumborum, okay. So this also, it is attached medially to the tip of the transverse process of the first lumbar, and laterally it is attached to the lower border of the 12th rib. So this is the this is how it arises from the body, and as medial and lateral arcuate ligament, the diaphragm origin is there from the vertebral body. Right. Next, where does it all insert? So all the fibers are inserted into the central tendon. So this portion is the central tendon, and all the fibers, they are inserted into the central tendon, which is situated in the medial depressed part of the diaphragm. Okay, so here in the central portion here, okay, this portion, it is all getting inserted. Okay, this is the central tendon part. So the central tendon is shaped, if you see here, this is the entire central tendon, this light colored thing. So it is a trefoil leaf, okay, presenting a median, right and left leaflets. Okay, so at the junction of, if you see here, the median and the right leaflet, there is a vena cava opening. Okay, and to the left, it presents a central opening that is presents a central point of decussation from which the four diagonal bands will radiate. Okay, so sternal fibers are shortest and those arising from the ninth costal cartilage will be the longest here. Okay, so you just have to remember they're all fibers get converged here and get inserted into the central tendon. Okay, so openings here. Okay, so there are major openings and there are minor openings. So major openings are the vena cava opening, the esophageal opening, and the aortic opening. Okay, so here what you have to know is at what point, which level is the opening and what structure passes through it. Okay, so first is the vena cava opening, situated in the, if you see here, it is situated in the central tendon at the junction of the right and this is the right and the median leaflets of this central tendon. Okay, so it is situated opposite the disc between 8th and 9th thoracic vertebrae. So the shape of it is quadrilateral. Okay, and structures passing through it will be the inferior vena cava. Okay, so inferior vena cava passes through it. Then a few branches of the right phrenic nerve and few lymph vessels pass through this inferior vena cava opening. Esophageal opening. Esophageal opening is situated at the level of 10th. So inferior vena cava, we say it is located at the level of T8. This is T10. Okay, so this is about 1.25 centimeter to the left of the midline. Okay, so this is elliptical in shape. Elliptical in shape. It is formed by the splitting of the right and left crus of the fibers of the right crus of the diaphragm. So what are the structures passing through? The main structure passing through is the esophagus, then anterior and posterior trunks of vagus, okay, vagal trunks, and esophageal branches of left gastric artery and lymphatics from the liver. Okay, these are the structures which pass through the esophageal opening. Then the last opening we have is the aortic opening that is located at the level of T12. Okay, so T8, T10, T12, all that is even numbers, 8, 10, and 12. Okay. So this shape is rounded. Okay, it's bounded in front by the median arcuate ligament and behind by the body of the 12th thoracic vertebrae. And on each side, there is the crust of the diaphragm. Okay, right and left crust. So here the structure passing is mainly is the abdominal aorta. Then we have the thoracic duct also passing through that. And sometimes the azygous vein, okay, when it arises as lumbar azygous, can pass through the abdominal aorta opening. Okay, so this aortic opening. Minor openings include, so there is a small triangular gap. Okay, so there is a small triangular gap which is known as the space of Larry. Okay, so it is present here near the sternal origin. Okay, so space of Larry. This is known as the space. It is a small space initially, but if it is a large, we call it as the foramen of Morgagni. So foramen of Morgagni is nothing but the small space of Larry which is present there. Okay, near the sternal origin. Then between the digitations, okay, between the digitations of that is costal origin of the diaphragm and the transversus abdominis muscle, there will be small openings through which the intercostal nerves and lower intercostal nerves and vessels will pass. Then between the costal origin of the diaphragm from the 7th to 8th, okay, from the 7th and 8th cartilages here above, where will be the musculophrenic artery, okay, which is the terminal branch of internal thoracic artery will emerge there. Okay, and behind the lateral arcuate ligament, the subcostal vessels and nerves will come. And behind the medial arcuate ligament here, we have the sympathetic trunk and sometimes the least splanchnic nerve will come. Okay, so these are some of the minor openings which are present. So the nerve supply of the diaphragm is mainly by the phrenic nerve, which is derived from C3, C4, and C5. Okay. So the sensory supply to the central part is by the phrenic nerve, and to the peripheral part, it is by the lower 6 or 7 intercostal nerves. So sympathetic supply is mainly from the celiac plexus. Okay. So action of the diaphragm, when we see, what does the diaphragm do? It is the principal muscle of inspiration. Okay. So when the diaphragm contracts, what happens is the lower ribs will be fixed and the vault of the diaphragm, if you see, it will descend and the vertical diameter of the thorax will increase. So here what is important is the clinical aspect. So when there is paralysis, when there is injury to the phrenic nerve, there may be paralysis of the diaphragm on the affected side. Okay. So it will result in collapse there, okay, of the diaphragm. And next is, if the space of Larry, which I told you, where is it is present at the sternal origin, okay, near the sternal origin, that space is large. We call it as the foramen of Morgagni. So sometimes through this foramen of Morgagni, what happens is the structures can herniate, okay. So that can also happen. Then near the costovertebral trigone or Boctelis triangle, okay, that is near the costal margin and the vertebrae. At that point, what happens is the diaphragm fails to arise, okay. That is from the lateral arcuate ligament is that part which is from the quadratus lumborum, fascia covering the quadratus lumborum, right? So when that part is not arised, what happens? There will be a large gap there, okay? And because of that large gap, what happens is the structures can penetrate and they reach the thoracic cavity, okay? That is called as Boctelis hernia, okay? So usually it is seen more commonly on the left side. Then there is hiatal hernia, which is caused by the dilated. Okay, so this is the foramen of Boctelic. This is the foramen of Morgagni, which I mentioned. Okay, and when the that is the esophageal opening is a little large, what happens is here two types of hernia can occur. One is the sliding hiatal hernia. Another one is the rolling hiatal hernia. Okay, so sliding hiatal hernia is more common and takes place when this gastroesophageal junction, okay, so this is the gastroesophageal junction. So this junction slides into the thorax through this lax opening, okay, so through that it happens. So this is associated with regurgitation of acids from the stomach, okay, and it appears like heartburn. Whereas in rolling hernia here, what happens? The gastroesophageal junction, it remains in the normal position. Here it is sliding, no? Here it is not sliding. It remains in the normal position. And the hernial sac containing the fundus of the stomach projects. So your fundus of the stomach is projected into the thoracic region, okay, by the side of the esophagus. So in this case, what happens is the patient will complain of pain, nausea, and dysphagia. Okay, so that is the things. So in the diaphragm, what are we going to write? Okay, so diaphragm. So you have to mention whether it is thoracic diaphragm. So what is that? Where it is present? Okay, thoracic diaphragm. So it is a musculo-aponeurotic structure separating between the thorax and the abdomen. So you write that. Then you will write about its two parts, that is the muscular part and the tendinous part, central tendon. Then you write about the origin. So origin is from three sources, that is from the sternum, okay, that is the xiphoid process, then from the costal cartilages, that is costal ribs and cartilages, that is lower 6. Then we have the vertebral. So vertebral comes from two things. One is three things. One is from the body. Okay, so the right crust, that is as a right crust, and the left crust, it comes. So right crust is upper 3 vertebrae, whereas this one is the lower 2. Upper 2 vertebrae. Okay. Whereas the second thing is from the median arcuate ligament and lateral arcuate ligament. It has the origin. And after that, you talk about the insertion. This was origin, insertion, Then openings, insertion is all into central tendon. Opening is, we have major openings and minor openings. Okay, so Bochdelic opening is not actually a commonly present. Only if the developmentally, if the muscle has not developed in that portion from the lateral arcuate ligament, it results in that. But normal openings are major and minor. So basically you talk, so that time you can make 3 columns. Okay, you can write the opening, you can write the level at where it lies, and what are the structures pass. Okay, so that way it becomes easier. Okay, so those are the things. Next question is the thoracic duct. So what do we mean? So here again, when you write about thoracic duct, so what are the things you are going to write in the thoracic duct? Okay, so you have to write about the length, okay, the definition, the length, the origin, the termination, the course of it, tributaries, and the clinical importance. So what is a thoracic duct? Okay, so first, what is it? That is the definition always. So it is an elongated, okay, it's, if you see here, it is an elongated, it's an elongated common lymphatic trunk which conveys chyle. Chyle is that lymph which is present in it, is called as chyle. And most of the chyle is basically what lymph is drained from the intestines. Okay, so that we call it as chyle. So it contains the chyle and most of the lymph from the body, and it, where it drains it into the bloodstream. Okay, so what area does it drain? So it drains the lymphatics from the entire body except for the right side of the head and neck region. Okay, right upper limb and the right upper half of the thorax, except for those regions which is drained by the right lymphatic duct. Rest, the entire body is drained by the thoracic duct. Okay, right. So what is its length? It measures about 45 centimeters and the average width is about 0.5 centimeters. So if you see here, the characteristic feature of this is, it looks beaded in appearance, okay? And it is provided with numerous valves. Why it gives this beaded appearance is, there is a number of valves, okay? Increased number of valves which are present there, okay? On this side. So that is why it gives a beaded appearance. Okay, so coming to the course of it, the thoracic duct begins from the upper end of this is the cisterna chyli. Okay, so cisterna chyli. So from the upper end of the cisterna chyli, it begins at the level of 12 thoracic vertebrae. It enters the thorax. So which opening does it enter the thorax? It enters the thorax through the aortic opening. Yes, we just learned that. So it passes upwards in the posterior mediastinum. Behind the esophagus, it passes, okay? And opposite the T5, so this is T5 vertebrae, what happens is, the thoracic duct, it slightly crosses towards the left side. Then again, it runs in the superior mediastinum. So below it was in the posterior mediastinum. In the upper part, it came to the superior mediastinum along the left edge of the esophagus. So this is the esophagus. Left edge of the esophagus, it comes. And at the root of the neck, it arches. Okay. And opposite the transverse process of C7, okay, it arches there at the level of transverse process of C7. And it will terminate in the angle formed at the junction of this internal jugular, left internal jugular and left subclavian vein. So at that junction, it will open. Okay. So this summit of this arch is about 3 to 4 centimeters above the clavicle, left clavicle. Okay. So at this termination, it is guarded by a pair of valves which will prevent the regurgitation of the blood into the duct. Okay. So that this blood doesn't enter the duct. So what are its relations? So at the aortic opening, so where it goes, okay, enters, there it is related in front to the median arcuate ligament, behind to the 12th thoracic vertebrae. Right side, there is a azygous vein, and on the left side, there is aorta. Okay, so these are the relations at the aortic opening. And in the posterior mediastinum, it is situated in the front. Here we are not seeing the anterior structures. So in the front, there will be this sloping. Okay, you know the boundary of posterior mediastinum, right? So anteriorly, it is the sloping surface of the diaphragm. So that is present. Then there is esophagus, separated by the right pleural races. Then behind there are thoracic vertebrae. Okay, and on the right side, there is a zygous vein, you can see. And on the left side, there is the descending thoracic aorta. So this is the structures which we see. Then in the superior mediastinum, in the front, okay, will be the arch of aorta in the lower part and left subclavian artery in the upper part. Behind will be the body of the upper four thoracic vertebrae. Right side, you see the esophagus, and on the left side, you will see the left lung and the pleura. So those forms the relation. Tributaries, when we come to the tributaries, a pair of descending limbs, okay. So a pair of descending lymph trunks, each drains the posterior intercostal lymph nodes of the lower 6 spaces. Okay, so intercostal lymph trunks you can see here. So they will be then pair of ascending lymph trunks. Okay, ascending lymph trunks draining the upper lumbar vertebral nodes. Okay, so descending and ascending lymph trunks. Then vessels which drain the posterior mediastinal lymph nodes, they also join. Then left jugular lymph node. Okay, left jugular lymph trunk here, you can see the left jugular lymph trunk, okay, draining the left half of the head and neck, and left subclavian lymph trunk, okay, left subclavian lymph trunk, they also join here. Okay, so both open at the terminal part of the thoracic duct. Okay, so these are the things which you should know about the thoracic duct, okay. So next we move on to the azygous system of veins. So azygous system of vein is very important system of veins which we see in the thoracic region. Okay, so what is it? How is it formed? Tributaries and clinical importance. So the azygous system of veins, what do we mean by that? They include those veins which are straight. Okay, if you see which are straight in course. Okay, they are paravertebral. Okay, paravertebral, that is next to the vertebrae in position, and they are not accompanied by their corresponding arteries. They do not have the corresponding, there is no azygous artery, okay? They are just veins. So what do they drain? Okay, so they drain most of the blood from the back and from the thoracic as well as the abdominal walls. Okay, so and they are provided with valves. Okay, so the azygous system, it will communicate with the vena cava in the front. Okay, in the front, it will communicate with the vena cava, and posteriorly, it will be communicating with the vertebral venous plexus. Okay, right. So here, azygous system of veins include the azygous vein, the accessory hemiazygous, and the hemiazygous vein. Okay, so we'll go one by one. So the azygous vein, when we say azygous vein, the origin is little inconstant. Okay, in the origin. So sometimes it may arrange directly from the superior vena cava, or from the right renal vein, or sometimes what happens, the ascending, right ascending lumbar vein, which is known as the lumbar azygous vein, okay, it will continue as the azygous vein. Okay, so either from the superior vena cava or from the right renal vein it comes, okay, or it continues as the from the right ascending lumbar vein. Okay. So this will ascend in front of the lumbar vertebrae. It enters the what is that, thorax, by either piercing the right crus or passing deep to it, okay, or it passes through the aortic opening of the diaphragm. And opposite to 12th vertebrae here, okay, near the 12th vertebrae, it will receive this one. What is that? A vein, which is formed by the union of right ascending lumbar and right subcostal vein. Okay, so this, when it doesn't arise from the lumbar azygous, we see this, okay. So that is, as I said, when it is not arising from the lumbar azygous, you see it arising from the union of right subcostal vein and the right ascending lumbar vein. Okay. Okay. So when it is here, let me just mention, correct myself here. So when it arises from the superior vena cava and right renal vein, we call it as the lumbar azygous origin. Or it may be formed by the union of right subcostal vein and the right ascending lumbar vein. Okay. Yes. So in the thorax, the azygous vein will pass upwards in front of the lower 8 thoracic vertebrae in the posterior mediastinum. And opposite the 4th thoracic vertebrae, okay, it will arch, okay, forward above the root of the right lung, and it will end in the superior vena cava. Just before the this one, what is that? Superior vena cava pierces the fibrous pericardium. Okay, so before it enters, the superior vena cava enters the middle mediastinum, not to open into the right atrium, it will come and join the superior vena cava. Okay. Right. So what are its tributaries? The tributaries here include the posterior intercostal veins. So if you see here, all the posterior intercostal veins of the right side, except, so if you see here, it is numbered from 2nd to 11th, okay? So you don't see the first vein. The 2nd, 3rd, and 4th intercostal veins, if you see here, 2nd, 3rd, and 4th, they all join together, okay, to form the right superior intercostal vein, okay? Right superior, and then it opens into the azygous vein. Then the venous trunk formed by the union of this right subcostal and right ascending lumbar veins. So this will be the first tributary. And terminal parts of hemiazygous and accessory hemiazygous. Okay, so you can see it. So these are the tributaries. In addition to that, there will be right bronchial vein and esophageal, pericardial, and mediastinal veins. So they also open into this. But these things you need to mention. So what is the importance of it? So in the obstruction of superior vena cava or inferior vena cava, azygous veins, they help in maintaining the collateral circulation. Okay, so that is why they are important. Then there is, okay, to this. So here one thing you need to know that sometimes when it is, instead of arching over the root of the right lung, okay, what happens is it comes over the apex and then it forms a groove there, okay, through the mesoazygous, means a part of the connective tissue, it is suspended and it opens there, okay. So because of that, what happens is the apex of the lung will get separated here, forming 2 lobes here. So this lobe, extra lobe, is known as the azygous lobe. Okay, this is a variation which we see. Okay, so coming to the hemiazygous and accessory hemiazygous. So hemiazygous vein, here if you see hemiazygous, is formed by the union of the left ascending lumbar vein and the left subcostal vein. Okay, it communicates below with the left renal vein. And the hemiazygous vein will enter the thorax by piercing the left crus of the diaphragm and receives the lower, that is 9th, 10th, and 11th. So this is on the left side, okay, 9th, 10th, and 11th intercostal, posterior intercostal veins. And it will end in the azygous vein at the level of T8, opposite the level of T8. Accessory azygous vein, it begins as a continuation of the left posterior, okay, left posterior intercostal vein. So left posterior intercostal vein will continue, okay, and it receives the blood from the 5th, 6th, 7th, 8th, okay, intercostal, posterior intercostal veins, and it will also open into the zygous vein, okay, at the level of T8. So that is about hemiazygous and accessory hemiazygous. So the things which you should remember to write will be, always when you write the answers, always give the headings instead of simply writing whatever you remember, okay? Always if you go in an order, it gives an impression that you know the answer well. Okay, so azygous system, what do we mean by azygous system of veins? Okay, so azygous system, what do we mean by that? Okay, so first will be the definition of it. So what does it drain? What area it drains? Okay, drainage area, what it drains. Then you will write about its origin, the 3 origins. Okay, that is from this, either from the inferior vena cava or from the right renal vein, okay, or from the union of the right subcostal and right ascending lumbar. Okay, so it can come from that. And then you have to write about its course, then termination. Okay, termination, tributaries, okay, which is very important. Then you write about the applied aspects. So here, tributaries can be, as such, can be asked as a 3 marks question. Okay, and the origin, the different origins can be asked as an MCQ question. Area of drainage can be asked, even in thoracic duct, area of drainage can be asked as a MCQ question. So we move on to the next question, that is the internal thoracic artery. Internal thoracic artery. Okay, so any artery, how do we write the artery? We write the artery as the origin, the termination, okay, where the artery originates, the termination, the course of it, branches, and its clinical importance. Okay, so if you see the artery, internal thoracic artery, it originates from the lower surface of the first, I think that you can see. So this is the internal thoracic artery. So it arises from the lower surface of the first part of subclavian arteries. Okay, so about 2 centimeters above the sternal end of the clavicle. So as the artery enters the thorax, no, so when it enters the thorax here, so about 2 centimeters above the sternal end of the clavicle, clavicles will be here. Okay, this is the first rib. So it arises. And as the artery enters the thorax, it passes downwards and medially behind the sternal end of the clavicle first, okay, sternal end of the clavicle and the first costal cartilage. Here, it is crossed from the, in the front, from the lateral to medial side by the phrenic nerve. Okay, so after that, it descends vertically behind the upper 6 costal cartilages, about 1 centimeter from the lateral margin of the sternum. And at the 6th intercostal space, here it will end by dividing into musculophrenic and superior epigastric artery. Okay, so that is the course of the internal thoracic artery. So branches here, we have the pericardiophrenik artery. So it accompanies the it accompanies the phrenic nerve and supplies the pericardium and the diaphragm. Okay. Then we have the mediastinal branches, the pericardial branches, and the sternal branches, okay, supplying these structures. Then there is anterior. So it gives a pair of, in each space, it gives a pair of anterior intercostal arteries. So upper 6 spaces, if you see, the anterior intercostal arteries are coming from the internal thoracic artery, whereas in the lower spaces here, 3 spaces, it is coming from the musculophrenic artery, because internal thoracic artery will end here in the 6th intercostal space. Then we have perforating branches. So perforating branches pierces the muscles, okay, of the upper 5 or 6 intercostal space, as well as pectoralis major, okay, and it supplies the muscles and skin there. In females, the 2nd to 4th, okay, these perforating branches, they are very well developed, they are large, and they supply the mammary gland. Then we have the terminal branch, musculophrenic artery and superior epigastric artery. So musculophrenic artery, it passes downwards and laterally behind the 7th to 9th costal cartilage and provides a pair of anterior intercostal arteries for each of these spaces. The superior other terminal branch, that is superior epigastric artery, it enters the rectus sheath through the gap between the xiphoid and the adjacent costal origin of this diaphragm. It will enter there and it will anastomose with the inferior epigastric artery. Okay. So what is the applied aspect? Why internal thoracic artery is important is it is used, okay, internal thoracic artery, since it is in close relation to the heart there and it's present in the thorax because of its easy accessibility. It is used, that is especially the left one, okay. It is used in coronary bypass surgery, okay, to improve the coronary circulation, okay. So, internal thoracic artery, you will write about, okay, internal thoracic arteries. So what are you going to write? Always any arteries, you should write first where it is originating, from which. So basically subclavian artery it is coming, where it is terminating in the 6th intercostal space. Okay, then its course. So what the structure? Process it before it enters the thorax. That is the MCQ question. Okay, that phrenic nerve. So you should write post, then you will write about its branches and what area they supply, and then you will write about its applied aspects. So these are the things which you need to write. So we move on to the next question, that is the typical intercostal nerve. Okay. So typical intercostal nerve, again here we follow the same order of origin, termination, course, branches, and clinical importance. So typical intercostal nerves. So when we say, what do we mean by that typical intercostal nerve? When the nerve is present in the that is in a typical intercostal space, we call it as the typical intercostal nerve. Okay. So as the nerve emerges here, what happens? It passes in the costal groove. Okay, it passes in the costal groove here. You can see. So the spinal nerve. Okay, spinal nerve, as soon as it emerges, it gives a, here we can see. Okay, so it is coming here. The spinal nerve, thorax, that is nothing but the thoracic spinal nerves. No? So they give, what is that? A dorsal branch and a ventral branch. So this ventral branch goes as the posterior intercostal nerve. Okay. So this dorsal branch will go behind, supplying the back. Whereas this nerve, it passes in the costal groove. Okay. And then it comes anteriorly, where it pierces the anterior intercostal membrane and divides into lateral and medial branches. Okay. So here in the course on the lateral side along the mid-axillary line there it will give a lateral cutaneous branch, which will divide into an anterior and a posterior branch. Okay. So this is what we see. Okay. So the nerve emerges. So this is the dorsal ramus. This is the posterior intercostal. It gives a lateral cutaneous dividing into posterior and an anterior branch. And this anterior branch will come forward, pierces through the anterior intercostal membrane, gives a medial and a lateral branch, supplying the skin of the respective side areas. Okay, so that is about it. So you write it in those. So basically, intercostal nerve seen, especially in herpes zoster and all, along those course, they will be affected. The nerves will be affected, as well as. Okay, the cutaneous supply. If there is an injury, the cutaneous area where it supplies will be affected. The next question, which you should know, is about trachea. Okay, so trachea, what is it? It is a windpipe. It is a membranous cartilaginous tube which extends as a continuation of the trachea of the larynx, and it ends at the sternal angle by dividing into two bronchus, right and left bronchus. Okay, so course, okay, extend where it begins at the lower border of the cricoid. So this is the cricoid cartilage. Okay, so it begins at the lower border of the cricoid cartilage. Opposite C6 passes downwards to the neck, that is through the superior mediastinum, and ends by dividing into right and left bronchi opposite the sternal angle. So the bifurcation of the trachea corresponds with the lower border of T4. So at the level of T4, okay. Or T6. So in the living at T6 level, in the cadaver, we take it as T4 level. Okay, right. So here, trachea, no, if you can see, trachea lies in the median plane, except near the termination, it is slightly deviated to the right side. That is mainly because of the pressure from the arch of aorta. So when we measure, it measures about 10 to 11 centimeters, breadth externally 2 centimeters in adults, 1.5 centimeters in females. And okay, so internal, not sorry here about this. It is internal. It is 12 millimeters in adults and 3 millimeters in newborns up to 3 years. This is of very much importance. Okay, because during surgeries and all, when we use the endotracheal tube, this lumen size is very important when we pass a tube. So it is usually 3 millimeters in newborns. It remains up to 3 years. And every year it will go on increasing 1 millimeter up to 12th year. Okay. After that, it remains constant. So it is formed as a diverticulum, that is from the foregut, no, where the esophagus forms. So there it develops. Okay. So it forms as a respiratory diverticulum. The trachea is formed when it is, then the groove, it gets separated, okay, by the approximation of these two ends, the septum forms and it separates and it divides, okay, into two portions which form the bronchus and forming the lung. So when we see the structure, it has got membranous part and cartilaginous part. Cartilaginous part is like a C-shaped cartilage, where posteriorly it is replaced by the muscle. And that is because we have the esophagus posteriorly, and it allows for the expansion of the esophagus there. Okay. So this is the things which you will write. So the next question is sternal angle. So sternal angle is otherwise called as the angle of Louis. Okay, sternal angle. So that is one more thing which is important. Okay, so what is sternal angle? Okay, so sternal angle is the junction of the manubrium sterni. Manubrium sterni. So it slightly it is inclined. So it forms an elevation part, which we call it as the sternal angle. And basically it is the manubriosternal joint. Okay, it is also called as the angle of Louis. So events here, what we have to know is events occurring at, this is very commonly asked in Viva as well as MCQ as well as in the, what is that, 3-mark question, okay. So it is an important landmark from which we use to count the ribs because the secondary rib articulates here, so we can count the ribs from this level. Then it is situated at the junction. So sternal angle, at the level of sternal angle, there are two discontinuous dermatomes. Means above the sternal angle, it is C4. Below that, it is T2. Okay, because C5 to C8 is taking part in the formation of brachial plexus. So there are two discontinuous dermatomes. Then sternum moves forward and backward at this sternomanubrial joint during inspiration. So it is the junction of superior mediastinum and inferior mediastinum. Trachea bifurcates at this level. Superior vena cava will pierce the what is that, pericardium to open into the right atrium at this level. Okay, that is beginning and the end of the arch of aorta at this level. Then there is also attachment of the superior pericardiophrenac ligament. Okay, and thoracic duct deviates from the right to the left side at this level. Okay, so these are the things which you need to write at the events occurring at the sternal angle. Okay, sternal angle, just revise. So the counting of the second rib is important. Okay, so it begins there. Then there is movement of the during inspiration. Okay, at the manubriosternal joint it happens. Then we have which one? That is discontinuous dermatomes, TC4, and below that will be the T2. Then we have the trachea bifurcation. Okay, trachea will bifurcate. Okay, at this level, bifurcate. Superior vena cava will pierce the pericardium. Arch of aorta will begin and end there. Ascending aorta will end there. Descending will begin there. Okay. And then what do we have? Thoracic duct will cross from right to left at that level. Okay. Superior mediastinum, junction of superior with the inferior mediastinum. So these are all the things. Okay. At least 5 to 6 you need to remember to write for an answer. So these are the things. Next, the last question is the transverse thoracic muscle. So transverse thoracic muscle is the big muscle here. Means it has 3 parts there basically. Origin, insertion, nerve supply, action for any muscle you should know. Okay, so this muscle, transverse thoracic muscle, we have 3 parts. Okay. So intercostalis intimus, subcostalis, and sternocostalis. So they form a part of the transversus thoracic muscle. Okay, so basically because of their placement across the thoracic cavity, they are called like that. So intercostalis intimus muscle, it is a part of this muscle and it occupies the middle 2/4 of the typical intercostal space. Okay, so it is present between the intercostalis internus and intimus muscle. Okay, so there it will be present, and this between the intercostalis internal intercostal and this intimus muscle, we have the neurovascular bundle which is present there. Okay. So it arises from the upper lip of the costal groove of the rib above and is inserted into the inner lip of the upper border of the rib below. Okay, so it arises from the rib above and gets inserted to the rib below. So basically, it will help in the to elevate the ribs during the inspiration. Okay. We have the subcostalis muscle. So we see it towards the inner side. Okay, subcostalis. Okay, so here if you see, so we will see here, basically it arises from the inner surface of the ribs. Okay, usually we see it from the level of third or fourth ribs. Okay, so we see it arises from a rib above and gets inserted to the rib below. Okay, lower border to the upper border of the, so lower border of the rib above to the upper border of the rib, 1 or 2 ribs below. Okay, that is subcostalis muscle. Then we have the sternocostalis, which begins from the inner surface of the sternum and it moves transversely like this fibers, and it gets inserted to the ribs, to the rib above at the sternochondral, that is costus chondral junction. Okay, where the cartilaginous part and the osseous part. Okay, that is the rib part of it meets. Okay, so at that junction, it will get inserted. Okay, so the nerve supply is by the corresponding intercostal nerves. So these are the things which you should write. So basically, they help in the movement of the thoracic cavity during inspiration. Okay, so with this, we finish. Thank you for watching. Okay, you can download the app if you haven't yet through Google Play or App Store. And you can also follow our content on the social media handles like YouTube, then the Instagram, Facebook, and Telegram. Thank you once again. So until next, see you. Thank you.